I'm Dr. Soundarya, consultant urologist at Preeti Urology Hospital, Hyderabad. Multi-tract PCNL. Usually, by placing more than 2 tracts, the risk of bleeding increases, increasing number of tracts, and also with the increasing tract size, we all know. But in this case, because of the complex anatomy and large burden stones in different calyces, by restricting our tract size to mini PCNL, that is 18 French and 16 French tracts, we could clear successfully near complete clearance in one stage. 4-tract supine PCNL was possible. Here we are showing a case of large burden left renal stone with a complex anatomy, that is 4-tract supine PCNL was done. The patient is a 51-year male who is a recurrent stone former with a large burden left renal stone. We had preoperatively counseled for 2-stage PCNL. This is the CT picture showing the large burden stones in all the calyces, upper, middle and lower, non-dilated system. Looks like long narrow infundibuli. These are the axial pictures showing stones in the upper, middle, anterior and posterior as well as the lower calyces. The patient is placed in modified supine position with the flank exposed, and this is the fluoroscopic image. It is not a single staghorn stone but rather large stones in all the calyces, upper, middle and lower. This is the RGP picture showing non-dilated system, long narrow infundibuli and with acute angle between the infundibuli and branching calyces. So with one tract it is not possible to reach all the stones. That's why we had planned for multi-tract PCNL. Retrograde, the lower ureter was not wide enough to accommodate the access sheath. That's why we had not planned ECIRS and therefore opted for a multi-tract PCNL. Initially, lower calyx was punctured, and initially only we wanted to puncture the middle and upper also. Once the guide wire was passed into the ureter, we went ahead with puncturing middle and upper pole, and after the guide wire was secured, we went ahead with dilatation. Since the upper pole, that is upper calyx, had a larger stone burden, initially that tract was dilated up to 18 French and the stones were cleared. Then we went ahead with dilatation of the lower calyx tract, and since the stones were a little smaller, we confined to 16 French tract and the stones from this calyx were cleared. Subsequently, we went ahead with middle calyx tract dilatation. That was again an 18 French tract, and all the stones that could be reached were cleared with this tract. After all these 3 tracts also, still we had 2 more stones which could not be reached by any of these tracts, and a stone guided puncture was done to the lateral stone. Guide wire was passed into the ureter. This tract was dilated to 16 French and the stone was cleared. But after this also, we had 1 more stone which could not be reached or seen with any of these tracts. Even we tried passing a retrograde flexible ureteroscope, but still all around the calyces when we searched, the stone could not be seen in the system. Even when we injected contrast, there was no filling defect seen in any particular calyx and it was not opacified. Therefore, we stopped the procedure at this stage, placed the stent and placed nephrostomy, and the contrast injected showed no adjacent visceral organ injury and the system was intact. So by restricting the tract size to mini PCNL, that is 2 18 French tracts and 2 16 French tracts, we could clear in the supine position in a single stage. Near complete clearance was achieved, and we had access to all the lower, middle as well as upper in this supine position, and the patient did well post-operatively. We intend to follow up the patient with subsequent imaging at the time of stent removal. Thank you.